Sir, now we are on live. We are good to go, sir.
I can start?
Yes, sir. Done.
Good afternoon, doctors. Welcome to this webinar on rational approach to viral respiratory tract infection. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products and portfolio, and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDMs in the world and is Asia's largest API manufacturing facility at SCZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. Today, during COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which, in August 2020, Hetero Healthcare received an award for Award of Pharma Excellence for COVID drugs. Today's webinar, Rational Approach to Viral Respiratory Tract Infection. We have got Dr. N. Sridhar sir as our moderator. Welcome, Dr. Sridhar sir. And Dr. Sri Krishna Surampudi and Dr. K. Pawan Kumar as our speaker. Welcome, Dr. Sri Krishna. Welcome, Dr. Pawan Kumar. Dr. Sridhar, N.L. Sridhar is practicing since 20 years. Sir is Professor, Apollo Institute of Medical Science and Research, Director, Neo BBC Hospital, Hyderabad, Treasurer Secretary, Twin City Branch 2021-22, 23-24, Joint National Coordinator, CIIP 2024-25, Presidential Action Plans, Secretary, PITS 2025-26, Medical Legal Expert, and the major achievements of Dr. Sridhar include 7 national and 1 international publication, Additional Chief Organizing Secretary, Pedicon 2025, Organizing Secretary, APPA, Pedicon 2016, Pharma Trade in Charge in all conferences since 2016, Vaidya Ratna Award 2023 from BC Roy Mother Fount. Welcome, Dr. Sridhar, once again. Dr. Sri Krishna Surampudi, sir, is MD DNB, Consultant Pediatrician, Professor and Head of the Department Pediatrics, Apollo Institute of Medical Science, Hyderabad. Welcome, Dr. Sri Krishna. Dr. K. Pawan Kumar, sir, is Professor of Pediatrics, MNR Medical College, Consultant Pediatrics, Omega Clinics, Scientific Convener, National Pedicon 2025, National Advisory, Indian Pediatrics Journal, Fellowship in Allergy and Clinical Immunology, Postgraduate Diploma in Pediatric Nutrition, Postgraduate Diploma in Developmental Neurology. Sir has won several awards, including Bharat Gaurav Puraskar 2023, Best Pediatrician of the Year 2023, Vaidya Ratna Awardee 2015, OGU Outstanding Academician of the Year 2023, Dr. APJ Abdul Kalam Health and Medical Excellence Awardee 2021, COVID Warrior Award, Asia's International Researcher Award 2023, Eminent Doctors of South India Best Research Award 2016, 18, 22, 23 by MNR Education Trust, Dr. Y.R. Reddy State Gold Medal, and Dr. Chandrasekhar Chowdhury Gold Medal 2023. National Award winner of Dr. V. Balagopal Raju Gold Medal for Scientific Research Paper 2010. Welcome, Dr. Pawan Kumar, and I hand over the session to Dr. N. Sridhar. Over to you, sir.
Thank you, sir. Thank you so much. Let me share the screen. So able to see the screen, sir?
Yes, sir.
Yeah, great. So first of all, I want to thank Hetero Pharma for giving this golden opportunity for all the doctors and for our team, where Dr. Sri Krishna Surampudi sir is the HOD Apollo Institute of Medical Sciences and Research, Jubilee Hills, and Dr. Pawan from MNR Medical College Consultant and also Professor of Pediatrics, and is having Omega Clinics in Kukatpalli, and he's a busy practitioner and very good in this orientation programs and nutrition, and he's became a national coordinator in All India Nutrition Workshop. So congratulations, Pawan. And today topic is a very interesting role of Oseltamivir in flu management, and we have a great panelist. So on the main contents are healthcare challenges in monsoon and their diagnosis, what influenza and its complications, and clinical evidence of Oseltamivir, and guideline recommendations of empiric use of Oseltamivir. So on these main headings, India and how we know about the influenza in India, and which season, correct time to vaccinate. So influenza is not a seasonal, just a seasonal viral illness, and it's a major global public health problem with significant morbidity and mortality, especially among children, the elderly, and adults also, and pregnant women, and those with comorbidities also. And influenza, as you know very well, influenza is a acute respiratory illness caused by influenza virus, a single-stranded negative sense RNA virus belonging to the Orthomyxoviridae family. And it has four types: A, B, C, D. Influenza A and B are responsible for most of the human diseases and seasonal epidemics, and especially influenza A in particular. It has a unique ability to cause pandemics due to its high genetic variability. So, what makes influenza clinically important is ability to undergo antigenic shift and drift, so leading to frequent epidemics. So, occasional pandemics are also seen, and that's the need for annual vaccine reformulation. That's the reason why every year the reformulation of the vaccine will be done. The bivalent, trivalent, now the quadrivalent. So like that, the valency will increase if the real epidemics and pandemics are seen. So it is a very short incubation period and highly transmissible, making outbreaks and rapid and difficult to control. From the clinical perspective, the influenza ranges from self-limiting febrile illness to severe pneumonia, ARDS, myocarditis, encephalopathy, and also secondary bacterial infections. In children, the influenza is a major cause of school absenteeism, hospitalization, and antibiotic misuse. So let us today's session will again revisit the influenza virus with a focus on its clinical relevance, evolving strains, and correct vaccine strategies and practical management challenges. And what is the drug, beautiful drug, which can be given. So this is the Indian data. 5 to 10% of all acute respiratory emergencies are due to influenza. 10 out of 100 child years suffers from influenza. Influenza associated with acute respiratory infections, 33 to 44 per thousand children per year. And you know very well, in 2009 pandemic, 22.8% positive for influenza is seen. And coming to 2019 up to March, there are 30,766 cases are positive and 1809 are died. So we have a purple book of immunization in 2022 brought by IAP. In that from I have taken this chart, month-wise trend of cases reported in India from 2014 to 2019. And there are two peaks you can see at between January and March, at February, and July and October. The peak is in August. So these are the two zones where we can that most of the influenza cases are seen this peak. And also some there is a post monsoon, like after rainy season there is a post monsoon from September, October, November, December. So there is a small peak of rise in post monsoon zones also. And there are in the same from the same purple book, we have seen mortality, morbidity, and hospitalization due to influenza lower respiratory tract infection 2017. There are hospitalizations, you can see numbers, 5.88 lakhs cases are registered hospitalizations, and 26,000 deaths are there. And year wise, I will not go in detail, but 2022, there are registered cases are 12,881 and 399. I can say the case which are informed and the DMHO and public health is very less when compared to the diagnosis cases. Normally, all the hospitals will not be proactive to inform the cases to district medical health officer and the statistics team. So cases what we get registered is, I feel, very less when compared to the present scenario. So this is overview of the influenza in India. So this is only bar diagram where in 2019 dark blue color, there are total cases of influenza infection is 28,798, whereas death are 1280. So, and the patterns of circulating strain in India, if you divide into 5 zones, totally different. In South India, we see that means our zone. So we see September to November is the peak. Whereas North India, it is the peak is January to March. And as earlier said, winter and monsoon also peak occurs. So there is a beautiful study, 7 years cumulative study in the Tamil Nadu. So done in the Department of Virology in 2019, King's Institute of Preventive Medicine and Research. There are 36,670 specimens were subjected for influenza analysis. It's a excellent study. Influenza positivity started with the onset of monsoon and peaks during the post-monsoon months also. That's the important why. When you the peak of the monsoon is July, August, September. So, but the cases are already in the peaks during the post-monsoon. That means October, November also. So that is the study in Tamil Nadu. So there are few challenges always when you see a case of influenza. Is it really influenza case or some other influenza-like illness or influenza itself or severe acute respiratory illness, SARI. So and it should be differentiated from COVID-19 also. So these are the we have to give in always a differential diagnosis because it may coexist with the adenovirus, it may coexist with the RSV virus. So like that we have to monitor, we have to clinical symptoms, we have to, and also we have to assess the case is it really fitting into H1N1. So let me invite our Surabud Sri Krishna garu to tell us about the influenza virus types and its please sir.
Very good afternoon to all. I thank Hetero Group for the giving this opportunity and Dr. Inel Sridhar for coordinating this interesting session. As we read in microbiology also that we have well-known three types are there, influenza A, B and C viruses. A virus cause more frequent epidemics and more minor antigenic variations also seen in influenza A, and this is the cause for the periodic pandemics across the world. Whereas a B virus usually infects small children with less than 5 years, and it's only human beings are affected, and usually local epidemics only. So what most commonly we do see that large scale epidemics mostly due to influenza A. Whereas influenza C virus infects both humans and swine, and it generally causes only mild respiratory illness and not thought to cause any epidemics at all. So previously there was a called swine flu. There is still doubt it must be the influenza A only. So the currently circulating human types at present in many hospitals are type A, in which subtype is H1N1 and H3N2 viruses. And the transmission of all these respiratory virus, like any other respiratory virus, is through the droplet infection, especially when the person suffering with influenza will cough it, sneeze, or talk it. And even hand to hand the spread also there, and it can land in the mouths or nose of the people. And generally, if any one person in the in a house is affected, and all other people also within 5 to 7 days, all other people in the house will be affected. So most of the healthy adults may be able to infect other people from day 1 onwards till day 7, whereas in children they may spread the infection for a more prolonged period. Yes, next. And this difference between various respiratory acute viral illnesses, which already been told by Dr. Inel Sridhar, in which the H1N1, SARI and COVID-19 are more dreadful diseases. And in that the COVID do have loss of smell and loss of taste also, and other systemic affections. Whereas H1N1 or the SARI will have almost a similar picture. This is one reason whenever there is an acute viral lower respiratory tract infection, because we cannot differentiate clinically between all these four types, it is better to start antiviral therapy, whatever is available, especially for H1N1 it is available. So this is a prospective study. It shows that Oseltamivir is a drug of choice. We used to read about amantadine, but at present the Oseltamivir is from last 10 years it's available, and it is known to control influenza cases very well. And this is one study in which there is a quite a good number of patients have improved well with Oseltamivir treatment. Next.
So now I request. This is a beautiful introduction of this the influenza, how it transmits, and also how it behaves. And now let us go into the case discussions. I request Pavan to start with the case one.
Yeah, thank you so much, Anil Sridhar sir, and also Sri Krishna sir for making the most complicated topic very simple. So we see these cases very often, but we don't have authenticity to start the most wonderful drug which we have in our armamentarium. So let us see how we can unveil that to the viewers. Today, viewers are going to get benefited because I have attended a webinar like this and I got this armamentarium, this wonder drug in our armamentarium, and that is helping me in my practice a lot. So I wish you all the viewers a great learning session today. So here is a very routine cases. I am very sure that Sri Krishna sir has picked up very common routine cases which we see in the office practice. Here is a 4-year-old boy who has admitted with a history of fever for last 6 days, along with cough and cold since 5 days. This is a very routine case. Parents are really worried about the child coughing. It's almost a continuous cough, they say. And here you can see the child's respiratory rate is tachypneic, is 45 per minute for a 4-year-old is definitely high, along with irritability, which shows, there is a decreased oxygen to the brain. So chest auscultation, we can hear bilateral crepitations and all other parameters in this child was normal. So this is with the weight of the child being 15 kgs. How do we proceed? Because a 15 kg 4-year-old child who is expected to be 16 kgs is a well thriving child. So how do we proceed? This is not a failure to thrive child also. So what is the initial management? What are the basic investigations which we need to do in office practice? And do you start an antibiotic on the day of admission? These are the common things which every pediatrician will encounter in day-to-day practice. Next slide, sir. Yeah. So this is definitely important. The initial management is always when the child is irritable, you got a CNS irritation is there. So immediately admit the child as the child is very sick. Start oxygen in a convenient method. That is in a non-threatening manner. Always start your oxygen with the non-rebreathing mask, which can provide up to 95% oxygen, which is easily available, which is of low cost. It doesn't cost more than 150, 200 rupees, but that will help you to achieve the 95% FiO2 for the child. As the respiratory distress is there, we have started him on oxygen and we have given supportive care like IV fluids and did basic investigations. So what basic investigations as a pediatrician you will think of? Complete bed picture, which will give you most of the information there, and chest X-ray are the basis for these small any investigations. But do we start an antibiotic on the day of admission? That depends upon the guidelines which we follow. If you are sure that this is a case of viral, we need not start. But IMNCI guidelines says that we need to start amoxicillin as the benefit of doubt. If later you have confirmed it is a viral, then you can stop the antibiotic. So that was for the guidelines given to the frontline workers in the field. So here the CBP is a normal picture, but chest X-ray is showing bilateral interstitial infiltrates which are present. So this is a classical picture most of the viewers might have seen in recent days. So, but there we stop usually, right, by seeing the infiltrates. But we have sent a viral panel. Fortunately or unfortunately, we came with a diagnosis like H3N2 was positive for influenza A. So that will give us an impetus that we can stop immediately the antibiotic and immediately start this wonder drug which was introduced as an antiviral drugs. So these antiviral drugs we are having there in our pharmacies, but we fear because of lack of experience and expertise and authenticity from the guidelines. So antiviral drugs can shorten. This is the wonder which we can see. It can shorten the illness if started within 48 hours of symptoms, and it should be prescribed by a doctor as antibiotics are ineffective against the virus. We all know that antibiotics won't work. It's for the bacteria, right? So antivirals are the drug of choice here, and Oseltamivir is the wonder drug which I was speaking. It can be started. The dose is also very simple, 3 mg per kg per dose. and the oral form twice a day for 5 days. This is a standard one, right? So we'll see the chart also. Yeah. So we need to educate the parents regarding the warning signs, because unless you tell the warning signs, the parent will think that the child will improve with the medicine. They keep on giving the medicine without paying attention to the warning signs. So we need to write in the prescription itself what are the warnings and the child warning signs explained. Please mention in the prescription, and also write if the fast breathing, trouble breathing is there, any cyanosis, that is bluish discoloration is there, not drinking enough fluids. This is very important aspect, because the child with increased respiratory rate more tends to have dehydration. So that we need to address, and not waking up or not interacting, very dull, irritable child. Please rush to the hospital immediately. That warning signs, please mention it on the prescription. Next slide, sir. So the complications of flu can be many. If we don't address that early, that will definitely take one of these complications. The most common is the pneumonia, then bronchitis, the ear infections, the middle ear infections. Because of the constant coughing, the eustachian tube, from there, then it goes to middle ear infection and all. And worsening of existing diseases. If the child is already having a case of asthma and COPD, and the child can worsen the symptoms. And sometimes we are seeing, not in India, but we can see in abroad, every case may turn up to be ARDS. They are very fearful of this flu. So, and sometimes it can result in death. So these are the complications of flu, which everybody should have. And what is the treatment of influenza? Largely supportive, because it's a viral one. So bed rest should be addressed, and increased fluid consumption to prevent dehydration. Cough suppressant should never be used, because we definitely should be very careful in using cough suppressants. Lot of now media attention is there on that. Better use what is safe and prescribable here. So antipyretics analysis at paracetamol can be given. And if the child is having fever and myalgia, don't hesitate to give NSAIDs. So most patients, this is a wonder, they recover in 3 days. You can confidently tell them, once you start Oseltamivir, you can say that these children will improve within 3 days. So malaise may persist for weeks. That also you should counsel. Otherwise, the parent will tell the child is not at all improving after that. So next slide, sir. So these are the wonder drugs which we have in our armamentarium, which we hesitate to use. The one is the neuraminidase inhibitor, and second is adamantines. So if you see adamantines, they have a limited role, because they are active against only influenza A virus, but neuraminidase inhibitors score high on because they are against both influenza A and B. So the drugs are like oseltamivir and janamivir come under neuraminidase inhibitor, and amantadine, rimantadine, which we studied during our pharmacology in that. So please remember, oseltamivir is the potent and selective inhibitor of neuraminidase enzyme of influenza virus A and B. So this is very important to understand how it acts. Yeah, the oseltamivir is a prodrug which is converted to its active form, oseltamivir carboxylate, in the liver, and it inhibits the influenza viral replication and pathogenicity. So this slide beautifully describes how this that enzyme is needed for to release the virions. The cell loaded with virions to get released, there should be breakage of this, the cleavage of neuraminidase should be there. But if you inhibit that enzyme, so the cells will be stuck in that. It's like putting the terrorists in the room and lock them from outside. So it is like that. It won't spread. It will also help the halt the viral replication, and also viral release also will be stopped by this. So that is the beauty of these neuraminidase inhibitors, and we need to definitely use it in our practical application. Next slide, sir. So once you have seen the mechanism of action, how it acts, you should be know that this is the first oral neuraminidase inhibitor. It is approved in more than 100 countries. The drug which is FDA approved, CDC approved, American Pediatrics approved drug is there in our armamentarium, but I don't know why we pediatricians, we hesitate to use it when the cases is a clear-cut case of viral infection.
Is a very interesting case, and detail about Oseltamivir, Dr. Pawan. Really, 3 mg per kg per dose, twice a day for 5 days has to be given. And this child was, once the diagnosis is made as influenza A, H3N2, immediately the child improved and got discharged on third day. So really, we can see miracle. This is a miracle drug in the case of influenza, where we feel very proud to be a pediatrician after this drug came into in our hand. So next case, Sri Krishna garu, please go ahead, sir.
Thank you, Sridhar. Here we have a 6-year-old girl came with fever, rhinorrhea for 6 days and cough for 3 days. This is a case of known case of bronchial asthma on irregular treatment. So when this child we admitted, there is severe bouts of cough, a mild fever is there, and bilateral crepitations along with mild wheeze present. So we got a doubt whether this is really an infected case or a flare-up of bronchial asthma. Here, how can we suspect it? As what is the criteria? As there is a past history, this could be even the simple case of a post-viral asthma. As we know, virus is an important trigger for the asthma flare-ups. So this could be related to the any virus that can trigger the asthma. That what our confusion was, whether to start antiviral or not, or should be because the typical wheeze is present in a known case of asthma. So whether this is the same case of again if asthma flare-up. But here we have to know certain facts. Any virus can trigger asthma, but among that, influenza is more known to trigger the asthma. Second is, moreover, the flu virus can cause more severe flare-ups of asthma. And similarly, the secondary viral infections and bacterial infections also very common in bronchial asthma cases. And the second thing is, because the already known case of bronchial asthma, there is even the flu is known to prolong the illness of asthma. That means asthma, because of the asthma, the flu infection chances very high. So we recommend flu vaccination for all children who are known to be asthmatic. On other hand, flu virus is known to give more flare-ups of acute asthma attacks. So we should be careful whenever any case of asthmatic come with the features of viral infection, that too with the lower respiratory tract involvement. It is better you start anti-flu therapy. That's what the decision we have taken. Next. So these are the WHO recommendation. So whenever any chronic lung disease patient, let it be an asthma or any other lung abnormality, and if they show any features of low respiratory viral infections, then empirical treatment with oseltamivir is recommended, and it should be started as early as possible. Don't wait for the viral panel reports to come. So you can send for lab confirmation, but there is no need for you to wait for it. Third is a negative lab test for H1N1 does not exclude the diagnosis in all patients. Therefore, you start it early, and especially if higher risk individuals have been exposed to patient with influenza, consider preventive treatment. That means any chronic lung disease patient, including asthma, whenever they admit with lower respiratory tract features, straight away you can start oseltamivir. That's what I want to tell this. So here, early, as a previous speaker, Dr. Pavan also told that early empiric therapy is always useful, whereas here early empirical antimicrobials is as per the guidelines. And whether to go for any other antibiotic therapy, it depends on the local hospital policy and the scope of the infection for that patient. Whereas if there is a history of travel or exposed to any animal influenza virus, straight away you can go for the antiviral therapy. Next. Here, this case is continued, and it is the X-ray is showing that you can see that the dark fields. That is the general rule is whenever you can see the eighth rib clearly on right side, it indicates that there is lungs are hyperinflated. Among the childhood diseases where there is hyperinflation of the lungs, it is asthma always comes first. Whereas in adults, usually emphysema, COPD and other do come. But in children, hyperinflated lungs below 1 year is a bronchiolitis, above 1 year is bronchial asthma. So this case is typical of a bronchial asthma patient with hyperinflated lungs. At the same time, bilateral interstitial infiltrates also seen. And the viral panel of this particular patient showed H3N2 positive for the influenza A. Next. So this child was given both oseltamivir along with asthma treatment. Here the doubt comes whether to start steroids in the very first set, because during acute illness, by giving the steroid, the dilemma comes where are we prolonging the viral infection? As you know, that the steroids are known to prolong the any infection. So we have taken, we were in first day we have managed this case with the continuous bronchodilators along with oseltamivir. After 2 days, we started on steroids. Once the fever controlled, she was discharged on even the prolonged asthma therapy.
Yes, it's a great case presentation, Dr. Surum Krishna sir. And first on this platform, I want to thank my head of the department, Sri Krishna Garu, for giving all these 4 cases, 2 cases presented, 2 cases we are going to. So he had allowed us to present in a public platform. Thank you, Sir Sri Krishna Garu, for giving this opportunity. And why this case was presented? Because all the plain direct cases, as the case 1, it's a influenza A, H3N2. We had treated with oseltamivir and solved. Problem is solved. But you have to, this case, why SAR had taken is because a comorbid condition is there. The patient is known case of bronchial asthma. He case with exacerbated breathlessness and exacerbated wheeze and other things. So the clinician shouldn't get confusion because because of the past history of the child is having and the exacerbation. You should keep in mind whenever the peak of the time influenza illness is there in the society as a common conditions. So we have to think this influenza, and whenever required, we have to send the viral panel and chest X-ray has to be done CPC. If the leukopenia is there, we have to think of a viral infection, and immediately we have to do the viral panel, which it came positive, and we treated with oseltamivir. Child improved, and then we had discharged the child on prolonged asthma therapy, and 5 days oseltamivir is given. Thank you, sir. Next case, Dr. Pavan. One more interesting with the rest of the 2 cases also with the comorbid conditions only. So it will be very interesting to listen. Please, Pavan.
Yeah, thank you, Sridhar sir. As rightly said, this is another interesting case of a 2-year-old boy who has a sibling with a nephrotic syndrome. So here is a boy who was admitted with high-grade fever for 2 days, along with cough and cold for 2 days and breathlessness for 2 days. So the child was admitted into the hospital, and the child is very restless, and his respiratory rate is 60 per minute, and the fever was 103. And what is the initial management as a pediatrician we should think? Do we want to start presumptive anti-flu therapy with oseltamivir? And what is the criteria? This we'll see in this study, in this case. So here the child is having respiratory distress. Please start life supportive oxygen in a non-threatening manner, and IV fluid should be started immediately because the child will be in dehydration. And if needed, we are ready to give a ventilatory support. Yeah, presumptive antibodies is always a debatable, but always start because of the low immunity caused by the virus, it can trigger the secondary bacterial infections, which we need to keep in mind. And do we need to start any presumptive anti-flu therapy? Yes. So the criteria is here. Next slide, sir. So here is the criteria when we should start antiviral treatment of influenza recommended for children is like if you are seeing like last season, last 1 month ago, we see that most cases have come to be positive. That is a season. When there is a like an epidemic it's going on in your area, please ensure that don't hesitate to start, because when you talk to your colleagues, they will also tell that a lot of cases with respiratory distress are coming positive. Do not hesitate. So suspected like influenza like illness with fever, either cough or throat, or confirmed influenza who are hospitalized or are having severe or progressive disease, and the children who are having underlying conditions, especially that increase the risk of complications of influenza, we need to be addressing it more. So antiviral treatment should be initiated as soon as possible, hourly, within 48 hours, regardless of the duration of the illness. So here also this child had CBP shows lymphocytosis, which is mostly like a viral with the neutropenia. And the chest X-ray is typical picture. This is what we are seeing nowadays: bilateral interstitial infiltrates and viral panel, which came in 24 hours later. It doesn't cost much. It only costs 3,000 rupees, but you can get the report in a day, which will confirm you. So here the child is positive for H3N2, and the dosage of guidelines for oseltamivir, I request everybody to keep screenshot of this and place it on your table. This will definitely help us. So you can see, if you want to remember one thing, like 0.25 ml per kg, suppose a 10 kg child, you can give it as a 2.5 ml twice a day. Very simple to calculate, right? So the dose is 3 mg per kg twice daily for treatment part. Here, interesting part is oseltamivir chemoprophylaxis. So please remember there is a difference between chemoprophylaxis and therapy. Therapy it's always twice daily, but here in chemoprophylaxis we give it as a once daily dosage, and once daily for 10 days we give here. For the contacts who are high risk of developing complications, we choose to give a chemoprophylaxis. So that's why this table is very interesting and important to keep on your table. Next slide, sir. So this same child, as I told you, he is having a sibling with nephrotic syndrome. Now parents are worried because this child is on steroid therapy and he got an exposure with this child. So what is the risk for him, and do we recommend any preventative therapy? This is the commonest question which parents ask you. And if so, is it antiviral drug or influenza vaccine? They ask us. So here, definitely there is no role of vaccine because it will take at least 2 to 3 weeks for the vaccine to get built up. And the child who is on steroids, we definitely won't give vaccine for sure. He should receive prophylactic antiviral drug. That is the underscore of this case. So here, when you have we give for the patient, we don't, there is no doubt about it. But you need to find out, is there any sibling who is having a high risk to get this? So we need to start chemoprophylaxis in that. Chemoprophylactically also, oseltamivir works very well. So in order to prevent complications in those children who are at high risk of contacting the disease, so better to start this prophylactic oseltamivir. The dose is same, 3 mg per kg per day, but here it is only for once a day and it should be given for 10 days. Please remember these 3 points. Once a dose, 3 mg per kg and for 10 days. Next slide, sir. So preventive therapy, this is what how we should give antiviral chemoprophylaxis is a recommendation for prevention of influenza virus as an adjunct to vaccination in certain individuals, especially those who are exposed asymptomatic children and who are at high risk of influenza complications, like the child which we are dealing, that nephrotic syndrome child. So they have not immunized. So we have to better start this preventive antiviral therapy.
So, thank you, Pawan. It's a very interesting case because the sibling is having nephrotic syndrome. The message is you shouldn't give vaccine when the child is having steroid treatment. So that's the one message. And second thing is the chemoprophylaxis works very well in the siblings if the child is suffering with cold and cough and exacerbation. So the chemoprophylaxis is half the dose of the normal normal treatment is twice a day for 5 days, whereas the chemoprophylaxis half the dose of the things OD for 10 days. So remember this, and you can treat very well in your OPD practice and emergencies. And now, Sri Krishna Garu, can you go ahead with the fourth case, sir, please?
Here, one more interesting case, actually a little bit tricky case it is. A 12-year-old girl admitted with fever, joint pains for 4 days, along with mild cough for 2 days. She is not a known case of chronic lung disease, and the child is showing is restless. If there is a cough and mild arthritis present, on auscultation bilateral crepitations also present. So it is more looking like a connective tissue disease. And sometimes there are features of a flu also there. So we got a doubt whether is it a flu causing the picture of a connective tissue disease. So what is the relation between any connective tissue disease along with and these viruses? As we know that most of the most of these connective tissue diseases and the diseases with the autoimmune picture like rheumatic or glomerular or IgA nephropathy, all these have viral infections and bacterial infections along with them. So it's a virus is known to induce the connective tissue disease picture in India especially. So this particular child is having a CPP as a normal picture, but the chest X-ray shows bilateral interstitial infiltrates, which is a typical of any viral infection. And ANA profile is normal, whereas viral profile shows the influenza type B positive. Next. So, as what is the association of any connective tissue disease with influenza virus? There are many reports, many studies were done, which is known to have among the connective tissue diseases, interstitial lung disease. If if at all it is an association among for all these, as we know, interstitial lung disease is a part and parcel of many connective tissue diseases. So interstitial lung disease can be for this, the one cause can be connective tissue disease, or even the recurrent influenza infections also are known to trigger the cases of interstitial lung disease. That means frequent viral infections might play a role in the development of and progression of chronic chest diseases. And so all patients with connective tissue disease should receive vaccination against influenza regularly. When there are signs of viral pneumonia, better start Oseltamivir in early cases. So we have started this case also as Oseltamivir, with Oseltamivir. Here, in this particular case, it shows as influenza B. And as I told previously, influenza B is more common in children less than 5 years, and above 5 years also it can come, but it is a milder course. So here, that is a picture of influenza B. Whereas influenza A is more severe, it can cause more severe illness in adults. It is the cause for most of our epidemics and even the endemic city also. Influenza A is more common. Similarly, the constitutional symptoms also severe, and complications secondary with like secondary bacterial pneumonia also more common with influenza A. Next. So there are some preventive measures also. We have non-pharmacological measures. As everyone knows, the effective hand hygiene can prevent almost 70% of respiratory infections also. And the proper cough and sneeze etiquette whenever a epidemic is going on. And see that all surfaces are cleaned properly, especially in the hospital areas, or any child is there in the family suffering with influenza. Whereas pharmacological is much more effective, as vaccination is annual, should be given. Here the rules for vaccination is, in India, all children less than 5 years and above 60 years elderly persons should receive vaccination every yearly. Whereas between these two ages, it is only depending on the chronicity, any chronic disease between 5 years to 60 years. If they are suffering with any chronic disease, they should be given vaccination. Whereas Oseltamivir, don't hesitate whenever there is a there are signs of viral lower respiratory tract infection. Straight away go for Oseltamivir for these persons.
Excellent, sir. All the comorbid conditions start from bronchial asthma. Second case. Third case is the sibling is having nephrotic syndrome. Third is looks like interstitial lung disease because connective tissue disorder. You remember one dictum: the viral infection, influenza, definitely exacerbates all the comorbid conditions. That's why we have to keep in mind whenever the comorbid conditions. If you take the history, if the patient says the child is having asthma, child is having other siblings or himself, the child is having nephrotic syndrome, or else any connected to joint pains, and child is elderly, 12 to 13 years old. So we have to keep in mind. So there are few questions. Already we had gone through this 40 minutes of lecture, but still the people who had joined late may be having a thorough, fast bullet answers from our panelists. And the first question to Sri Krishna Garu: has the incidence of viral infection increased, sir? What could be the possible reasons?
Yes, previously we used to think that every infection was bacterial infection, but two, three reasons. Now later, the awareness about viral infections is more clear compared to 30, 40 years back period. The second is, with the usage of antibiotics, even the typical pictures of bacterial infections also has come down. So now what we are getting, most of the respiratory infections are definitely viral infections. And there is a say that whenever there is a natural calamity in a widespread, there is a definite surge in that within a 1 year. In that particular area, there is a surge of viral infections. If you see that in that way, that in recent 100 years, every time let it be a World War picture or any area where there is a volcano or even the tsunami. After that, within 1 year, in that local areas, lot of viral infections are known to increase in that. So they are known nowadays. We are seeing more awareness is there. More investigations are also available for to know specific viral infection. So you can say that it is overall it is increased.
Thank you, sir. Now, generally, how soon the child is brought to pediatrician? Dr. Pavan, can you? Because
Yes, sir.
they will have their own treatment protocols, and after 3 4 days, we commonly see the children will be brought to us. So, what is your experience? Can you please?
Yeah, there is a lot of change in the perspective of the parents also, sir. Nowadays, we are seeing there is a trend, a change, because now previously parents used to wait for 1 or 2 days, and they used to bring these cases once the child is coughing very badly, the worst cough ever. Then only they used to come to the pediatrician. But now, because of a lot of awareness being spread on the YouTube or Instagrams and all, so we are seeing this parents are now they are coming little early only, and they are finding out whether the child is going to go into that complicated station and all. So that is really helping us to start this drug very early, so that we can prevent most of the complications related to this flu. So
Yes.
nowadays we are seeing that change in trend in our place, sir. I don't know. I think most of you also agree with that, the practitioners. And
Yes.
if you find that the child is brought little late, and if you find that this is a sure short case of breathlessness with cough, continuous cough, please do not hesitate. Don't think that within 48 hours only I should start. No, as early as possible, whenever your child is brought to you, please do not hesitate to initiate this wonder drug. That is the take home from this.
Yes, that's true. It's better to start the medicine early. That's the reason why we request the parents, if the child is having cold, cough, and severe intoxicity with headache, body pains, definitely go to the nearest healthcare professional so that they can take a call on to start the Oseltamivir or not. And second thing, you know very well, because it can reduce the lower respiratory tract complications and also hospitalizations and also antibiotic use. These are the three things where we have to keep in mind. So the next question is, should Oseltamivir be started empirically or after investigation? Sri Krishna garu.
This was already cleared guidelines for when we are discussing the cases. And whenever you suspect acute lower viral respiratory infection with a viral typical picture, straight away you can go for it. Of course, we have many other viruses like RSV and the rhinovirus or even COVID, and many others are there. But among that, most dangerous one is H1N1, because it's throughout the years. COVID, of course, only for few little period, but H1N1 is known to give maximum morbidity and mortality. Second thing is, if you start early within first 2 or 3 days, the outcome is much better. So don't wait for viral panel. Straight away you can start Oseltamivir. Here.
Sir, there was a study, please.
Yes. Continue.
Yeah, thank you. So here there is a reducing occurrence and severity of pneumonia due to H1N1 by early Oseltamivir admission is seen. There was a retrospective study on this of 442 patients were conducted, sir. And median time from symptom onset to Oseltamivir administration was 5 days. So they have divided into 4 groups: less than 2 days, 3 to 7, 8 to 14, and more than. So here there's really this is the study where had shown more promising for the oseltamivir to start with within 48 hours. So the child was improved very well. The sample size, which were the medicine started before 2 days, oseltamivir administration was done. The child was improved and not landed in any complication hospitalization. So this is a beautiful study for the supportive for the oseltamivir administration. So the next question, Dr. Pawan, what are the factors on which clinical response to oseltamivir depends?
So it depends upon many factors like the child immunization status, and any previous comorbidities the child have, like immunodeficiency states like malnutrition, chronic infections like TB, HIV. If the child is on steroid therapy, like in our case of nephrotic syndrome, malignancy, and all these chronic conditions which will have a direct impact on the immune status of the child. But what is the one factor which helps us to, give the best clinical response is the early suspicion, the high index of suspicion and early initiation of antiviral therapy is the, way to go. That is how we need to approach to these cases because you can prevent not only the virus replication in the same child also, but viral shedding also can be prevented. So that the other family members also can be easily protected. If the elderly is there in the families, so those should be also can be protected by early initiation of this drug. So it is early high index of suspicion and early initiation matters a lot here, sir.
Excellent. So the next question is generally how long should Oseltamivir be administered, Dr. Sri Krishna
This
garu?
also very nicely and table is given here. Here, what is the difference is that the treatment is 5 days only, but twice daily. Whereas the chemoprophylaxis is once a day for 10 days. The total cumulative dose is same, but it is the same divided into 5 days for therapy, whereas 10 days for the chemoprophylaxis. And the dose is the available is at 3 mg per kg body weight, and it is available as 75 mg capsule for adults, whereas children, its suspension is available as 12 mg per ml. That means 5 ml contains 60 mg. So with this 3 mg per kg body weight, you can give the dose. That's
Yes, sir. So here simple mathematics is if a syrup is there 0.25 ml per kg, it should be given twice a day. So if a 10 kgs child comes to your clinic and child is positive or you want to start oseltamivir, better to give 2.5 ml twice a day for 5 days. That will be easy. Or you want to start a chemoprophylaxis, give him 2.5 ml. If the other siblings are having similar complaints but not gone for investigations, so better to give 2.5 ml once a day for 10 days. That's the chemoprophylaxis. Nicely said, sir. And Dr. Pawan, do you prescribe antibiotics concurrently?
So as it's very important to understand that for a typical viral flu, antibiotics are not at all needed. It's like you opening your neighbor's door with your key. It will not fit into that. It will not open. So similarly, antibiotics working for virus is definitely a big no. So better not to because pediatricians are responsible antimicrobial warriors. Resistance to prevent AMR. So we need to definitely be careful in initiating. If it's a clear-cut case of bacterial infection noted, secondary bacterial infection is found, then definitely you are likely to start antibiotics as per the IMNCA guidelines and also per the hospital policy also. But in the initial outset, definitely no antibiotic is needed in the OPD especially.
Great. So next question. How is oseltamivir tolerated? Are there any major adverse effects of oseltamivir?
we have given for many cases. I think can say that more than 50 cases in this particular season, and we have not seen any particular major adverse effects with oseltamivir. But as per the literature, there can be some serious skin reactions like blistering, peeling, loosening of the skin, or red skin lesions can happen. So whenever you feel that it's because of the medicine, immediately stop the medicine and give supporting care.
Yes, sir. So the next question is any contraindications and precautions to use of oseltamivir, Dr. Pawan?
Yes, sir. As Sri Krishna sir has neatly elaborated, it is very well tolerated drug. Even in my practice, also I haven't seen any case of intolerance to the drug. But one should be careful with the if the child is known has serious hypersensitivity to any of the product of the components of the drug or the siltamavir itself. Previously, the child had some reaction. We should keep in mind. And there are very rare chances of this probenecid and dichlorphenamide can increase the risk of side effects of the oseltamivir that we need to be a little bit careful. Otherwise, as end of this is very safe drug to use. We can easily start as an empirical also, so that gives the impetus for us. It's very safe drug to use, but use it wisely. And when you are suspecting a case of viral flu, immediately do not hesitate to start it as early as possible.
Yes, great. So there are no contraindications and precautions to use of oseltamivir because it's a very much safe drug. And recently, 5 days back, I got three children, sister and both the brothers. And sister was very much toxic. And so I have done the viral panel where influenza B came positive in this case, and I started Oseltamivir. And since other two siblings also, other brothers also are having a cold and cough, but they are active, so I kept chemoprophylaxis for them. Three children got improved within 48 hours. Recent, not even 5 days back. And I think Mirza and these
I
people
think
came and have shown
this
the
case
results.
has to be included, sir,
Yes,
to
yes. Next time I
both
will include.
chemoprophylaxis and all in one
So, so
family.
child was both three children are improved within 3 days, and
Great, great.
mother was very happy. So, like that, it's this all our experience. And if you listen for this say webinar or seminar or say, this direct lecture also, they will be benefited. Doctors will be benefited, and patient ultimate benefit goes to the patient. So, this is the summary. Proper diagnosis can and early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory complications, hospitalizations, and antibiotic use. And WHO and American Thoracic Society and Ministry of Health and Family Welfare recommends empiric use of oseltamivir. Thank you, and thanks to the Heteropharma and Mirza and Samriddhi and Prishant who had given this opportunity for today. And shortly, Kolkata Pedicon is there from 16th onwards. See you doctors in Kolkata. Thank you.
So
Thank you
one
for
request for the
inviting me.
viewers, sir. One request
Yep.
for the viewers. Don't take whatever we said. You try on your patients. This we are just giving you a direction. You once you develop the confidence, you will not leave it. You will also say that this is a really wonder drug. What Hetero has brought it in a syrup formulation. That is very important. So thank you, Hetero, for helping us. It's a symbiotic relationship what we have with you. So you are helping us to treat patients in a most effective way possible. Thank you so much.
Sri Krishna garu, any closing remarks?
No, just use it as told it. Previously, whenever any pneumonia comes, because even though we know that it was a viral pneumonia, even though we know that it's no antibiotic is specific, we used to give antibiotics. Instead of that, now identify that what is, see the viral picture, and if viral picture with a lower respiratory tract infection, straight away go for the oseltamivir. That's what my feeling.
Lovely, sir. Thank you very much. Thanks, Dr. Sridhar. That last case which you mentioned was really interesting.
Yes,
Chemoprophylaxis and treatment. I mean, really interesting. And thanks, Dr. Sri Krishna. Thanks, Dr. Pawan. And thanks all the doctors who took time and attended this. Thank you, sales team. Thanks, Mirza. Thanks, Bhuvan. Thanks, Samriddhi. Thank you. I wish you a very pleasant afternoon and evening. Thanks, sir.
See
You
you.
can sign
See you
off.
all.
Thank
Thank you.
you.
Sir, see you,
Bye.
see you, sir.
See you,
See you.
Pawan.
Thank you.
Thanks, Dr.